At the foundation, we believe that everyone deserves access to exceptional health care. And our mission is to fund and support patient care and innovation at Zuckerberg San Francisco General Hospital because we believe in health equity and access to care for all. So through our grant making and program support, we invest in programs that are built on the foundation and scaffolding of innovation and equity, giving way to new models of care. And it's exactly programs such as AI, predictive analytics for better health outcomes, which you will hear more about today, that exists because of our shared commitment to our vision and our mission related to health equity. As a supporter of the foundation, you enable this life-changing work that happens day in and day out in ordinary times and during the most challenging times and in times of crisis. So thank you for your support. Today, we are honored to be joined by Dr. Susan Ehrlich, CEO of Zuckerberg San Francisco General Hospital, and cardiologist Dr. Lucas Zier, who is the Director of Cardiovascular Performance and Outcomes, and also the co-founder and co-director of the Applied Machine Learning and Artificial Intelligence Laboratory at ZSFG. Susan.
Good morning, everyone, and welcome. I'm so glad you could all join us today. And Kim, I really want to thank you for understanding the need for this discussion this morning. I'm really looking forward to it. You can't open a newspaper, turn on the TV, or drive down the highway without hearing about or seeing the words artificial intelligence. It has captured everyone's imagination and curiosity, and there's so much being written and said about it. Here at ZSFG, we are harnessing this technology to take care of a population that we serve, which is the population that is really impacted by social determinants of health, that is traditionally underserved. And I want to emphasize that this is groundbreaking work. We are harnessing this tool, AI, to focus specifically on our population, which is something that isn't being done anywhere else. So I'm really excited that we have the opportunity to hear from our expert, Dr. Zier, and have a discussion about it this morning.
Great. Thank you, Dr. Susan Ehrlich. Let's get into it and let's talk about how technology plus healthcare can actually come together in these new ways. So, Susan, I'm going to start with you. At the beginning of the pandemic, your staff was deployed, as we say, to the COVID Command Center, and they used predictive analytics to do the crisis planning for San Francisco. Can you describe the impact of that work that happened both for ZSFG, but also our entire community?
Sure. That was a really incredible opportunity to think about using predictive analytics to help us with our response to the pandemic. And the way that worked, it was one of Luke's partners, Dr. Jim Marks, who was the leader of what we called the advanced analytics team at the command center. He also worked with Lizzie Connolly and a host of other folks from our IT unit at ZSFG and the Department of Public Health to first create a database that included all the variables we needed from all the hospitals in the community. And then the team was able to take all of that information from the hospitals to not just monitor what was going on in the moment with COVID, but to actually predict how COVID was going to impact us down the road. And that proved to be an incredibly important tool. We met weekly and sometimes more as a group of hospitals to look at these data, think about them critically, and plan ahead for the resources we need to care for the community. And it was that database in part, as well as the response that we had, that we were able to have with the database, that allowed us in San Francisco to have the lowest death rate from COVID of any major metropolitan area in the country. So we really learned firsthand how important not just using predictive analytics was, but to use the data to really inform our response to the pandemic. And that, I would say, was the beginning of a lot of the work we're going to talk about here this morning.
Thank you. That is truly exceptional that we had the lowest death rate during the pandemic compared to other cities or other urban areas. And it's my understanding that it's about 800 deaths between January of 2020 and to around July of 2022. So I hope that everyone listening today really grasps the magnitude and the extraordinary work that was done at the COVID Command Center, thanks to Susan, your team, and Luke, your partner in this work. So let's, along that line of really leveraging technology for the greater good, the support the foundation provides is unique and gives ZSSG the opportunity to have what we call strategic risk capital. And strategic risk capital through philanthropy gives the opportunity to try new ideas or models of care. So let's talk about one of the ways we've really launched that forward for this project through our Zuckerberg Patient Care and Quality Improvement Fund, known as ZPCQI. And what does that mean to you and your team, Dr. Ehrlich?
Well, I just can't say enough about how important the ZPCQI funds have been for us. And I'll explain that by putting it in the context of what I saw my work to be when I joined ZSFG as the CEO in April of 2016. And of course, there are a lot of things that were important back then, but two of the most important things were to make sure that we had an equity lens to everything that we did. And we can talk more about how that played out over time, but also to really follow the principles of data-driven improvement. We're a lean organization and we have lots of tools, strategies, and principles for using that. But when it really comes right down to it, data-driven improvement is the way that we function here, and specifically on behalf of our population that we serve here at ZSFG. The ZPCQI fund could not be more important in supporting this work. And in addition to just generally supporting us with data-driven improvement and supporting our Kaizen promotion team that allows us to do this work, it has supported fellows who have worked in particularly important areas. And Dr. Zier has been one of those fellows. So he could not be doing his work without that fund. There are many other fellows that we've supported. I can think of Dr. Hemel Kanzaria, who started the social medicine team along with another group. And that has also really allowed us to use data-driven improvement to serve our population in a slightly different way. But I can't emphasize enough that our work in this area would not be possible without ZPCQI and without incredibly talented leaders like Dr. Zier, who bring this work to life.
Wonderful. Thank you, Dr. Ehrlich, for that description. I think it helps everybody understand the context of how Dr. Zier started his work. So with that, now I'm going to ask you, Dr. Zier, a few questions. Let's start. Perhaps you can begin by introducing the concept of artificial intelligence known as AI and predictive analytics, and how ZSFG is actually using this technology. How were you inspired to actually think about using AI and predictive analytics in your work related to cardiology? And I know I'm not supposed to ask too many questions at once, but what were you seeing and what motivated you to actually move that ahead in your work? That's a lot of questions.
Thanks for those questions, Kim, and thanks for the opportunity to speak about the work today. So, in medicine, prediction is not it's not a new concept. So for example, every time a doctor recommends that a patient take a cholesterol medication to reduce the risk of heart attack, that's based upon a risk prediction scoring system. As Dr. Ehrlich talked about, there was a lot of predictive modeling that occurred around, the COVID pandemic to understand, trends and to try to understand, the direction that the pandemic was going to, intervene and to, flatten the curve and improve the outcomes. But I would say until fairly recently, those risk prediction scoring systems were based on relatively simple methodologies, and also not necessarily applicable to specific populations or kind of general risk prediction scoring systems. So then when we think about predictive analytics, as Dr. Ehrlich kind of alluded to, predictive analytics uses data to predict future trends and events. And in medicine, that's particularly important because, we're trying to, improve mortality, reduce the risk of dying, really benefit our patients. So how does predictive analytics relate to artificial intelligence? Well, artificial intelligence it's an umbrella term. Broadly, it's technology that mimics human cognition in order to perform a variety of tasks. But there's a specific subtype of artificial intelligence called machine learning. And machine learning is a concept that you may have heard of. It really uses algorithms that are trained on large swaths of data that can be used to produce a variety of tasks. But one of those tasks is risk prediction. So the question is, how is this, why is this relevant to our population? Why did I become inspired to apply this to our population? Well, in 2017, our health system realized that we had a pretty significant problem with heart failure. Our typical care was leading to outcomes that were relatively suboptimal. We had high readmission rates, so our patients were coming back to the hospital at a far more frequent rate than other safety net settings. We actually had the worst readmission rate in California amongst peer institutions. Patients were unfortunately dying at a higher rate than compared to peer institutions, and we had inequities in our patient population. Particularly our Black African American population had higher readmission rates and suboptimal outcomes. But what we understood is that we had, through capture of data, through our electronic medical record and through other sources of data, we had vast swaths of data that we could leverage to potentially improve upon those patient outcomes. And in a safety net setting, we don't necessarily have the ability to, for example, hire a team of additional clinicians or resources to do population health management. So we understood that we had a lot of data, and we also understood that we could leverage technology to help to solve this problem. So the first thing that we did is we used machine learning to develop customized predictive algorithms that really helped us to identify the highest risk patients in our population. So we were able to deploy these algorithms through our electronic medical record. And we were able to essentially monitor our entire patient population 24 hours a day, 7 days a week, to figure out who is at highest risk of an adverse health outcome. However, just identifying patients at high risk that's necessary, but it's not sufficient to improve health outcomes. So we were also able to build a customized deployment platform that leveraged logic-based treatment pathways and high-risk patients to actionable interventions, both on the individual clinician level. So we deployed it at the point of care for clinicians who are taking care of heart failure patients, in the hospital, and also deployed on the population level to identify our highest risk patients, and then proactively go out into the community, find those patients, and develop specific treatment plans to improve patient outcomes. And I have to say we've been quite successful in this endeavor through the utilization of these technologies. So our readmission rate declined by 13 percentage points. So we went from the health system with the highest heart failure readmission rates in the state now to the lowest among peer institutions. We saw significant improvements in mortality. So patients prior to the intervention were unfortunately dying at a higher rate than compared to the patients after the intervention. So patients, we've actually been able to improve survival in our patients with heart failure. And we've seen a closure in our equity gaps. So in particular, our Black African American heart failure population actually has lower readmission rates than compared to our general population. And so I think the success here was leveraging technology, leveraging our data. And in addition, it was incorporation of social determinants of health, as Dr. Ehrlich mentioned. So really just thinking of patients holistically, incorporating not just medical data, but also social determinants of health data into our model to increase predictive accuracy. And then also link those patients to interventions, not just to treat heart failure, for example, but also to assist when we could in the treatment of social circumstances that may be adverse and leading to poor outcomes.
Thank you, Dr. Zier. That is so impressive. I hope everybody caught that. A 13% reduction in readmissions and 6% reduction in mortality. That is really impressive. So congratulations. And importantly, you did that, as you said, by closing the racial gap, in particular for Black African American men who were most at risk and finding themselves being readmitted more frequently. So that is really a great setup to ask my next question around what do you think sets ZSFG apart by using predictive analytics and machine learning, sort of bringing in these lens? What sets you apart?
Yeah, so I mean, I think the first thing is because of support from the foundation and the ZPCQI fund, we are a safety net, community hospital that is able to leverage and deploy this technology, I think, in a population that might not necessarily otherwise have access to, to these resources. So, Kim, as you mentioned, there's a lot of excitement around artificial intelligence, and I'm sure many people on this call have interacted with things like ChatGPT, and even kind of your daily work. Artificial intelligence is being used widely. But there's not as much of an effort right now to deploy this technology in populations that we serve, and also in community safety net hospitals. So I think just the opportunity to do that is really exciting, and it positions us both to really benefit our population, and also potentially to lead and set an example for other similar institutions in the future. I think also there's this term in medicine that we use this term precision medicine, where we like to kind of the future is we want to develop like very patient specific treatment plans, or at least population specific interventions, because we know, for example, that interventions that may work in one population may not work in another. And so I think one of the advantages to what we've been able to do at San Francisco General is we've really been able to study and deploy and create interventions specifically within this population that is applicable again to a population that is traditionally underserved, but also can be shared and deployed with other areas. Another thing that differentiates us is if you look at traditional risk scoring systems, or even other groups and companies that have developed prediction models, is they oftentimes don't incorporate a patient's social circumstances within the risk prediction algorithm. So we've been able to leverage a lot of information around a patient's social circumstances, which we call social determinants of health, to include in our models. And we have data showing that by capturing and leveraging that data, we actually improve the predictive performance of our models quite significantly. And that is one of the reasons, as I mentioned, that has led to improvement in our health outcomes. We actually published a paper recently showing that a lot of the risk, if not all of the risk, associated with readmissions in medical circumstances. And I think the last thing is, because of this support, we really feel like we're, on the cutting edge. Maybe we're not competing with places like OpenAI and Microsoft and Google, but our group is particularly interested right now in this new sort of type of model called a large language model, which if people have interacted with Chat GPT, that's an example of a large language model, where you can interact and that model is predicting the next, the next word in a sentence, and it can do a lot of things. It can do a type of a model like that can perform a variety of tasks. And so we're really excited that in the future, because of this support, that we can actually train a large language model specifically on data from our patient population, and we can deploy that to perform a variety of tasks. So we can, for example, use that to chat with patients and remind them to go to appointments. We can use that to improve our billing so that we are able to recoup money that we might not otherwise have received because of limitations in resources. We can leverage that to perform a variety of risk prediction tasks. And we can also use a model like that to provide point of care decision support for our patients. So we're really thrilled to be able to deploy this technology within this health system. And we think for those reasons that sets our program apart.
So can I ask you to share maybe a patient story so that it makes it real for some of the folks who are listening? Someone comes into the hospital. Tell me what happens. They come into the emergency room. They've had a heart attack. They're Black African-American male, based on some of the data you showed. What's going to happen next? And make that real when you say social determinants of health, food, housing, transportation. Like, what exactly are you talking about so that those who are listening can really understand how you might approach a patient and take care of them?
Well, let me answer this question by first kind of describing what was happening before we had this technology, because I think that will contextualize what we've done. So patient is admitted to the hospital with heart failure. There was a lack of standardization in how we cared for those patients. And there was also not necessarily attention to a patient's environment that their social environment was affecting their disease. So the result of this was, like, for example, a patient that maybe in the chart had a history of being unhoused or was actively experiencing homelessness. As part of deployment of this program, we spoke with providers and asked them how they were taking care of heart failure patients, to sort of inform our interventions. We got a lot of responses such as, like, well, patients who are unhoused, may not be able to take their heart failure medications. And so I'm less likely to prescribe them specific heart failure medications. I feel like I don't have the tools to address their social needs. Like, housing is a very complicated problem. I don't know how to deal with this. I don't know how to link somebody to transportation. And so what we saw that what resulted in the care was that there was a lack of standardization. Patients weren't necessarily getting access to all the, state-of-the-art medications that are needed to care for patients with heart failure. And there was also frustration and a real inability to link patients to resources that might improve their health outcomes. So now when a patient is admitted for heart failure, within the electronic medical record, we've created a customized sort of home base for patients with heart failure that providers go into, and it really walks them through the steps of caring for patients with heart failure, both in the medical and social domains. And what we've heard from providers is that it actually streamlines that process. So rather than having to search through the chart and look to see, was this patient on a medication in the past? Are they a candidate for this? Have they tried this intervention? It really just directly tells them, like, look, these are the medications that this patient should be on. And these are the social interventions that might benefit this patient. And so it streamlines the workflow for the provider. It walks them through a very sequential process that we call a care pathway. It alleviates cognitive burden. So the provider is not necessarily having to sort through the chart and deal with all these other things. So they're provided with very specific treatment recommendations, and they can, it limits the amount of time that they're spending, going through the chart, documenting things. And so much more cognitive effort is spent actually caring for the patient. And then it also, again, links patients specifically to resources around 14 different social domains. And then additionally, what we've done is we've developed, we have a population management team that we call the HEART team. And that team is responsible for caring for our highest risk patients. And previously what they would do before we had predictive modeling is they would look and see over the last couple of months who was admitted to the hospital most frequently, you know, who was having the worst outcomes in the last couple of months, thinking that past would predict future. But through our predictive models and through integration with the electronic health record, our heart team now actually gets alerts for patients that are at high risk and need to be intervened upon. And they also are much more forward thinking. They're looking at the prediction of who's going to get readmitted in the future, who's at risk of mortality in the future. And so they can then actively seek out those patients because of a predicted risk, as opposed to, you know, something that historically, you know, occurred and may not necessarily, you know, mean that that's going to happen again in the future.
Thank you. Thank you for that example. Dr. Ehrlich, would you like to jump in there and share a story or two, or some examples that are on your mind?
Well, I just wanted to underscore how important what Luke is talking about from the outpatient perspective, because what is unique about our patient population is, and important in this case, is that many of the patients we serve have heart failure as a result of substance use disorder. And that is not typically the case. And sadly, it's very common among Black African American men. It's true, you know, it could be true for anyone, but we see that quite a bit in our population. And so as a primary care provider who sees many youngish men with heart failure, you know, I can see that a lot of those folks do have substance use disorders. And so that was one of the things that Luke's team was attentive to, was making sure that the outpatient heart failure care is linked to services for substance use disorder. And we've developed, you know, quite an impressive array of addiction care services, both in the inpatient and outpatient area. But, you know, in addition to the standardized care in the inpatient area, we have standardized care in the outpatient setting that includes referrals and access to substance use disorder treatment. So that is critically important to making sure that our patients get the best care that they can get. And I also want to underscore another thing, which is that there are predictive models that you know, Epic has, that other you know, companies have, but they don't take these social determinants of health into account. And that is really what is unique about our population health work that Luke is describing. And it is, you know, it's not sold in stores. So we have to create these things on our own. And with respect to managing the population, this is really the holy grail. You know, we want to look at, for example, the 60,000 patients who are served by the San Francisco Health Network, identify the people who have or are at risk of morbidity and mortality, and provide them exactly with the services that we need. And our electronic health record, Epic, is configured to have discrete variables that address social determinants of health, but that's not perfect because they don't always get entered accurately. So this large language model work that Luke is talking about, that is really the next phase of this work, is incredibly important because it can extract the data about social determinants from the provider and the provider team notes, making the model that much more powerful. And then finally, we don't want to just lead in doing this work ourselves. We want to connect with other safety net providers in California and even around the country, so that we can bring all of our data together, because the larger these data sets are, the more powerful they become in allowing us to predict very precisely what is responsible for morbidity and mortality.
Thank you, Dr. Ehrlich. So both of you, kind of on my mind is, how do you see public hospitals or healthcare institutions actually leveraging AI more generally to bridge healthcare into these underserved communities? And you've kind of touched on that, both of you, by addressing these questions related to social determinants of health, but that's more on an individual basis. So how do you see that in terms of kind of pushing out to other public hospitals? are these models scalable? Are they, generalizable? Some basic questions related to that, and how you two would consider bridging that. Either one of you can jump in. Susan, do you want to go first, or Luke?
Well, I think we definitely have already started the process of involving other systems, just so we can make sure that we have access to as much data that is specific to our populations as possible. But I'll let Luke say more in detail about that quest.
Yeah, so I think that what is the role of this? I think the first question is kind of what is the role of this technology and these this type of population, this type of health system? Well, I think that if you look at the marginal cost of artificial intelligence compared to what would be needed to, for example, do population health management in a heart failure population, for example, there is an upfront cost to building and deploying these technologies. So, for example, it took us a year and about $1 million to build our specific algorithms and our deployment platform in the EHR. But over the life of this program, we have been able to retain over $6 million of at-risk pay-for-performance funding for the health system. So what that means is that in this day and age, hospitals and health systems have to meet specific performance metrics in order to get and retain specific funding. And so safety net hospitals, safety net health systems that's well documented in the literature, are penalized disproportionately compared to other health systems. And so I think it's a testament to sort of the cost benefit analysis here, how much this can actually return. And again, these are dollars that are going specifically to care for clinical programs, right? For programs that we might not otherwise have to care for patients. So unfortunately, I think safety nets can get caught in a little bit of a cycle where you have poor performance, you don't get funding, that impacts the clinical care that you can provide, that leads to worse performance. And I think while there is an upfront cost, I think that leads to that investment over time has paid off, and I think that's demonstrated in our population. I think the other thing, so we know, for example, that in the literature, and this is if people are familiar with literature, there's an algorithm that was used to predict sepsis. That's like a severe infection in the bloodstream. And that model was trained on 3 specific health systems in the middle of the country, which is a very specific patient population. And then it was kind of promoted and deployed broadly. And essentially, when that model was deployed at other health systems, it was demonstrated that it wasn't accurate, and it was just leading to a bunch of alerts that were popping up in the health system. And providers just started to ignore it, and actually detracted from providers' ability to do work. So what is the takeaway from that? The takeaway from that is that you really have to have models that are specific for your patient population. And so what we are excited about, and what Dr. Ehrlich was alluding to, is that we really hope that potentially with support in the future, that we can develop a data collaboratory among safety net hospitals, so that we can create models, particularly large language models, that are applicable and provide good prediction and good assistance to clinicians at the bedside, specifically for patients in this population. And so we're not there yet, but we're building towards that. But again, it gets back to this concept of precision medicine, right? We can't necessarily develop a model that is going to be applicable to everybody across the U.S. or the world, nor should we at this point, because of the technology that we have available. What we should be doing is we should be leveraging the data within our own health systems and like health systems to create technology that is applicable to specific patient populations that can really impact care in those specific patient populations.
Thank you. You mentioned cost benefit analysis, and I see a question that's come into me. Are you documenting that and doing any studies related to that, or planning to do that as you move ahead to show the cost benefit of using this technology?
Yeah, we have a paper that we're hoping to get published very soon, in which we describe all of our outcomes, including the improvement or the retention of funding that we were able to achieve as part of this work. And in the future, as our group continues to grow and we have a little bit more bandwidth, we also hope to demonstrate the cost effectiveness through specific cost effective analyses within the safety net setting, because again, we think that there's really an important role here for this technology to save money for health systems like ours, and money that can be specifically given back to patients to improve health outcomes.
Thank you. And I'm sure Dr. Ehrlich is happy to hear that too, overseeing all aspects of the hospital. Algorithms have bias. So let's talk about that. Let's talk about bias. How are you ensuring that the work that we're doing here at ZSFG is mindful of bias and inequities? And also, how can you maybe use some of this technology to improve access for patients, regardless of their socioeconomic or racial background?
Yeah, so I think this is an incredibly important question, and I think probably one of the most important questions before somebody is considering actively deploying a model in the health system. So we've taken a couple of steps to try to limit bias. I think eliminating all bias is not fully possible, but I think having attention to this issue and also taking as many steps as you can to limit bias is really important. So one is that, so when we look at the performance of our models, when we compare it to other models that are not trained in our specific patient population or are trained in a population similar to ours that don't capture kind of the entirety of a patient's medical and social situation, we find that they don't perform well, and they perform with specific biases. So I'll just to give one example. There was a model from a company that was produced that predicted or was trying to predict risk of no-show rate to clinic appointments, right? Because the idea being that if somebody had a high risk of no-show rate, you could schedule another patient along with them to potentially fill the gap because there was a high risk of no-show rate. That model was shown to be very, very biased towards particular patient populations, and so patients were actually their care was being detracted upon because they were getting less time with the clinician because there were patients who were double scheduled. So I think one of the things that we've come to realize, and we've published on this, is that you have to incorporate as much data, not just about their patient's medical situation, but around the social determinants of health, because we know that increases performance, increases predictive accuracy, increases positive predictive value, things along those lines. And so we have made a really significant effort both to screen for social determinants of health within our health system so that we have that data available for us, and then incorporate it within our models. And so I think just trying to capture as much social determinants of health data, and for example, not just relying on race, which is oftentimes used as a proxy, an inaccurate proxy for social determinants of health, leads to a lot of the biases in the algorithm. We also have hired, as part of our team, a data scientist who has expertise in this concept called recourse within machine learning and artificial intelligence. And so this is most commonly studied within the financial sector. So patients can sometimes get caught in these algorithms where they're just, commonly predicted to, have, poor credit and not get access to credit and things like that. And so people have introduced this concept of recourse as a way for actually individual patients to intervene, and or individuals to intervene and say, hey, actually, this algorithm is biasing me in this particular way, and to try to kind of remove themselves from that cycle of bias. And so we are actively looking at ways at how recourse can be used both on the provider level and the patient level if we identify biases in our algorithms, to try to break that cycle of bias that then leads to predictions that are inaccurate and biased. And I think the other thing, again, as I mentioned before, is that you really need data that's specific to your patient population. I think some of the greatest biases that we've seen is these models that people try to apply from populations that really just are not analogous. And so hence our push right now, and our intent to develop this data collaboratory where we can share data across different safety net health systems, and also come together and share ideas around the deployment and use of this technology, and also how to limit biases within this particular patient population, which admittedly is apt to potentially, have biases that could affect algorithms and deployment of the algorithms.
Thank you, Dr. Zier. I'd like to invite all of our audience participants to send questions in via Q&A. Some of them have been coming in, and we've been integrating them into the questions along the way here. For example, algorithms have bias, just popped in. So I want to encourage everybody to do that before I ask this kind of my last question here, planned question of Dr. Susan Ehrlich. You mentioned you are optimistic, and that is definitely something that you have felt that AI can add to optimism for the future of your hospital, but even more broadly, how it can affect patient care beyond ZSFG. So how do you talk to us a little bit about what you look forward to seeing with this technology?
Sure. Well, there are so many possibilities. And first, I just want to commend Dr. Zier for his intention around equity. I think what I want to point out about his response is that, there are disparities everywhere we look in medicine, including at ZSFG. And the first step to addressing them and correcting them is having intention, creativity, courage to look at them. And not everybody does that. So I just want to call that out, because that's something that we really aspire to here at ZSFG. And I think the work that Dr. Zier is describing is a very good example of that. Second, in terms of the possibilities, here at ZSFG and in the Department of Public Health, what we really aspire to is excellent population health management. And I alluded to this before, but what we mean by that is we serve about 60,000 people in the network overall, and that includes care that's provided at the hospital and the clinics. And what we really want to be able to do, ideally in that population, is to ensure through all the means we have at our disposal that they live the healthiest lives that they can. And so, traditionally, what we had was clinics and hospitals. And the more we sort of dig into this, that has to also then include services that address social determinants of health. So prescriptions for food, transportation, linkages to housing. And that's great because the California Medi-Cal program is really being transformed as we speak to include a lot of those services. And AI is also a really important piece of this, because what it does is it allows us to efficiently and effectively really zero in on the things that are causing morbidity and mortality, and not just understand what they are, but then prescribe treatments in the inpatient and the outpatient settings to be able to improve their health. The thing that comes to mind right now is unintentional overdose deaths. We know that that's a scourge in our city, and in the nation overall. Well, it would be aspirational to be able to predict who is most at risk to die from an unintentional overdose death, and then be able to identify those people and prescribe and assist them with the best practice treatments for that issue. So there are just so many possibilities, and I really see this as being a very, very important tool that we have in our toolkit in healthcare to be able to improve people's health overall.
Great, thank you, Dr. Ehrlich. Let me ask a question here from our audience. This one's probably for Dr. Zier. Have the best practices you're discussing here for AI and equity been adopted by other hospitals, such as UCSF?
Yeah, so I think people familiar with the field understand that this is rapidly evolving. This is a rapidly evolving area. I was joking with one of our data scientists the other day that I think actually the heart failure models that we developed like in the last year might actually now be outdated with the development of large language models. So the field moves so rapidly that practices and best practices change depending on the application of the technology, the type of technology that is being deployed. We work have contacts. I mean, we're all UCSF faculty, and so the ML AI community at UCSF spans multiple institutions, including ZSFG. I think at this point there's not specifically an articulated best practices approach to AI or ML at UCSF, but I know that is coming, and I think additionally. What needs to be done is there needs to be consensus both on the individual patient level, but also because this technology is becoming so widely applicable on national and international levels. So the short answer is yes, the community, this is something that's really important to us. We talk about it, but the actual codification of that is coming, but it's not there yet.
Okay, thank you. Another question that has popped up is, and maybe Dr. Ehrlich, you might want to answer this one. How do you use this to educate trainees and others? And how does it help train physicians in good medical care, sort of bringing along the next generation for this work?
Well, one thing that's really impressive about the way UCSF approaches medical education that is really different from when I was in training is that medical students are involved in data-driven improvement. They learn, in their first year how to construct an A3, which is basically an improvement charter. They work with us at ZSFG and at other UCSF campuses to identify problems that are really important and then work on solutions to address those. So medical students and residents are deeply involved in doing data-driven improvement. Luke would be able to say whether he knows if any of them are involved specifically in the work that you're doing, say, around heart failure readmissions. But it's just a matter of time, I think, before that is part of the menu of things that they're involved with, just because of the approach and the intention to do data-driven improvement work that is embedded into what we do in the hospital.
Great, thank you. I'm going to combine a couple of questions here. Dr. Zier, you've talked a lot about the social determinants of health, as have you, Dr. Ehrlich. So, are there any social determinants of health that kind of stand out in particular? And then the other piece of this is, how are you involving family members? You talked about the patient, but often family members need to be involved or are involved. And how are you working through some of that into the patient care?
Well, I'll just start. Generally, we know, based on a lot of research that's been done in this field in our Center for Vulnerable Populations and with a number of our faculty on campus, the root cause of a lot of these health issues that our patients show up with is their lack of housing. I would say housing kind of trumps all of it in terms of being a root cause factor that really detracts from health. Luke can talk about how housing fits into his predictive model and prescriptive model, but based on what I know, I would say housing is among the most important, if not the most important.
So, Dr. Zier, maybe you can talk about how you might involve the family and how do you actually get adherence to what you're recommending, like taking the medications or whatever it might be.
Yeah, so I mean, I think that so just to contextualize how we think about AI in a decision support context, we think about it as a co-pilot, right? So the intention of this technology is not to take over the role of the clinician or take over the role of a provider at the point of care. It's really to be an assistive tool and to free up the provider to really not have to think about kind of the lower level, more rote things, and allow them to use our cognitive effort to solve the more complex problems, like if somebody has complex social situations, how to help with adherence to medications. So I think that in terms of adherence to medications and involving family members, so that is an important part of what the predictive models help to identify. We don't. So for example, one of our social determinants of health that we assess for is social support and an environment. And so, if that's identified, then we might, for example, make a referral to a specific, social support system, or provide them with a case manager or something. Whereas previously, without this technology and without screening for social determinants of health, the way that we would make that referral would just be based on a provider kind of thinking like, I think this patient's at high risk, and they would just refer them to a case manager. So I think in general, look, I don't want to give the impression that our technology has solved problems around social determinants of health. I think that it has made our providers more attentive to how much risk is associated with how much medical risk is associated with social determinants of health. So, for example, this heart failure work that we did, I mean, essentially what we saw in our analysis was that it was really substance use, and particularly intravenous substance use, and particular housing statuses that were most associated with poor heart failure outcomes. Now, those are probably the most complex social determinants to solve, so to speak, right? I mean, how do you solve housing in San Francisco? Addressing substance use is more complicated. But at least providers are aware of that. And I think making linkages to resources that exist within the city where those linkages otherwise were not available is a step forward. And I also think that in terms of social determinants of health, there is lower hanging fruit. So for example, we have been able to better identify patients that are at risk for poor health outcomes because of just lack of transportation to the hospital, right? That is something that we can solve. And so it's both allowed us to identify, which risk factors are associated with a patient's predicted risk, and also to intervene on the social determinants of health that we can, in particular on some of the lower hanging fruit that is much easier to intervene upon.
Great, thank you. So one of the other questions that's just popping in, what are the costs to do this work? And so what do you need funded? What my understanding, and I'll take a stab at this, and Dr. Zier, you can jump in. My understanding is that you need more capacity for informatics. You work in teams, so physicians and providers, data scientists. In order to make it sustainable over time, you need to build it, at least at this point. What we've been doing is building it upon the electronic health record, Epic, and then that creates sustainability and continuity of care. And then it's my understanding we need about $3.5 million to really kind of do the scalability for the heart failure readmission program, increase processor capability, and then also do this work with a data collaboratory. Is there anything else you would add, and how does that lead into maybe collaborating with other public safety net hospitals as part of this data collaboratory? So I think 3.5 million is the number that I think I've been seeing in budgets coming my way. So anything you'd want to add to that?
Yeah, I think we're at an inflection point in our work right now in which we've had investment from ZPCQI and the foundation to allow us to develop a successful program for heart failure. And we've learned a lot from that program. And we also understand that to scale this to other health systems and to make this technology more widely available for these types of populations, we need to go in a couple strategic directions. So one has been alluded to several times is the development of this data collaboratory, this collaboration platform. So for example, right now, when we talk about large language models, we kind of have two options. One of them is to use large language models that currently exist, like, for example, ChatGPT, or other models that are created by the large tech companies. We have concerns that these models may potentially be biased for many of the reasons that we've talked about. So the ability to create a data collaboratory in which we could develop foundational large language models specifically for the deployment and safety net hospitals to do this kind of multitask processes like we discussed would be, I think, really transformative for safety net systems around the country. I think that additionally, so that requires a data collaboratory, it requires processing power, and it requires some strategic investment in people to help us to build those things. So that's really what we're excited about. And then of course we'd love to disseminate that. And with the direction of large language models, we think that there's a tremendous ability to, or tremendous opportunity, I should say, to be able to scale and share that type of model with other health systems to hopefully improve health outcomes, like we've talked about in heart failure. And again, the last thing that I will say is what we've done with heart failure, we hope to replicate in other chronic disease conditions, because there's no reason to think that this approach wouldn't be successful in diabetes or hypertension or chronic pulmonary disease. And again, having a flexible algorithm that can take on multiple tasks like a large language model, we think is the key to be able to address not just individual diseases in sequence, but potentially to address a number of chronic diseases kind of in parallel.
Great. Thank you, Dr. Zier. And I've also understood, and you have shared with me, that you would hope to be able to move this into maybe some opioid and fentanyl prediction to avoid overdose. And I know in order to do that work, that's like another 2.3 million. So I'll just put that out for those listening. We've got this heart failure opportunity to scale, but also we've been looking at this opioid and fentanyl situation and how we can be part of what I say is be part of the solution, join our work here and support Luke and Susan. So Dr. Ehrlich, I'm going to ask you a final question. We've got just a couple minutes here before we need to shut down here. Any particular example of work where you'd like to see impact, adding on to what Dr. Zier has shared with us?
What I think what Dr. Zier is saying, in part, is that there is a lot to be done to build the capacity of the team in order to have the tools to address any problem we might put in front of it. From my perspective, what we really want to be about is addressing the true north goals of the organization. And what are those? Equity. We've talked a lot about equity and how important that is to be considered in all the work we do. Safety, preventing bad outcomes in healthcare is still a huge intention that we all need to concern ourselves with. Quality and flow, making sure that we are accessible to all the patients we need to be accessible to. Patient and staff experience, we haven't addressed those directly, but kind of imbued in all of this work is the idea that the better we can do with identifying patients correctly, treating them appropriately, that is only going to advance our ability to treat patients better and to have them have a better experience, and for our providers and teams to be able to have better experiences in providing care, which is incredibly important right now. And then last but not least, financial stewardship. The more precise we can be with targeting patients who have very high risk and have very expensive conditions to treat, the more effectively we can use the funds in healthcare. And we all know that that is critically important these days. So in my mind, the true north is what we're about, and it's really what Luke's work should be addressing.
Thank you. Well, thank you, Dr. Ehrlich. Thank you, Dr. Zier. Our time has come to an end. I think today's panel is incredibly illuminating. And I think for those of you who were listening, the opportunity to use artificial intelligence and predictive analytics to improve patient outcomes and lower costs is really extraordinary. And to be able to do all of that with a health equity lens comes through in all aspects of the work that Dr. Zier and Dr. Ehrlich have shared with us today. So I want to thank all of you for joining us and supporting the foundation so that we, in fact, can do the grant making to support this work. So thank you all for joining us, and special thanks to Dr. Zier and Dr. Ehrlich. Please have a great day ahead. Thank you.
Thank you, Kim. Thank you, Luke.
Thank you. Thanks for inviting me.